Hello, everyone, and welcome back to the BackTable Urology podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. We are your hosts today, Aditya Bagrodia, and this is E Silva. Oche, how you doing today?
Hey, what's up, man? Pretty good.
Good. We're really excited to introduce our guest today, Brad Hornberger. Brad is a board-certified physician assistant and an instructor in the Department of Urology at UT Southwestern Medical Center. He's been doing this for some time now, and I think we're going to get some invaluable insights from his experience. So, Brad, welcome. Thank you for spending some time with us on this Sunday. How are you doing today?
Doing great. Thanks for the opportunity to be here. Looking forward to it.
Good. So let's just jump on into it, Brad. You were one of the first PAs in the Department of Urology here. How long have you been doing this?
So I did my last clinical rotation at UT Southwestern's urology department, I guess in November of 2002. And so at that time, it was a great experience. It was, frankly, a month-long job interview for myself and for the department to see if we were both good fits for each other. They were looking for a PA at the time. And of course, everything worked out, and I started working for the department in February of 2003. I've been there since.
So as a student, you were able to rotate in urology at that time?
Yeah.
Okay.
I knew I wanted to be in Dallas, and so I was looking for positions and found the position and spoke to Dr. Rohrborn at the time. And, I had the opportunity to do an elective rotation with the department. And so I took the opportunity, and of course, happy I did.
And, in your perspective as a PA, what about urology is attractive?
Well, I think, you'd probably hear the same thing from the residents, during the interviews. For me personally, I knew I wanted to work in a surgical subspecialty. That's kind of basically where I was at the time. And, of course, getting into urology, you learn that it's so varied. There's internal medicine, there's oncology, there's getting involved in the operating room, outpatient procedures. So for me, it's the mix. It's the variety that really, I think, has kept me there. That, and frankly, the innovation that happens in urology. You've been around long enough and you realize that, every 5 or 10 years, there's new paradigms that come in. And, I don't know if that happens in every specialty, definitely not in family medicine for sure. So definitely keeps your interests and keeps you on top of your game.
And that's probably my answer to why I'm a urologist.
Yeah.
The same is you get everything. I think ENT, ophthalmology, maybe they have the same. You do clinics, you do a little bit of procedures, but yeah. So that's why I'm also a urologist. So when you first started as a PA, what was your scope of practice? First you were shadowing. How was it when you first started?
Yeah, I think for me, at that time, I did a lot of shadowing for probably the first 6 or 8 weeks. I spent a lot of time with Dr. Rohrborn. Whenever he was in clinic, I was in clinic. Whenever he was in the operating room, I was in the operating room. And as I gained more experience, I started seeing patients in the clinic, and mainly they were non-surgical patients. As you know, there's a fair amount of urology that is non-surgical in nature. And so I had a kind of limited practice at that time. Of course, I wasn't going to see new prostate cancer patients or new renal masses, et cetera. And so as my experience matured, then the types of patients I saw and I grew, my practice grew.
But since the first time, first day one, you started seeing patients on your own?
No. I would say I was shadowing Dr. Rohrborn for at least 6 or 8 weeks,
Okay.
And then after that, I actually would rotate through with the different, subspecialists we had in our department, frankly, in large academic medical centers, everyone's their own, specialty. And so I'd spend time with the urologic oncologists. I'd spend time with stone experts, female urology, et cetera. And during that time, I was building up my clinical practice. So of course I wasn't seeing 20 or 25 patients a day at that time. I may have been seeing 8 or 12, and so it gave me more free time to shadow and maybe help out with some of the new patients with the different surgeons there in clinic as well.
That's great, Brad. And, I think making sure you're coming in from PA school with a nice broad exposure to all the different fields. And just like for residents, you want to start dialing in. Now, maybe kind of getting in a little bit into the nuts and bolts. So were you screening new patients that you would be interested in seeing, that you think that would be appropriate? Can you speak a little? And I know it's obviously been a little while, but now that you're also involved in kind of onboarding new PAs as well, what have you learned over time is a successful way to, ramp people up towards independent or, less supervised practice? Or is that even the goal?
Yeah. I mean, I think every practice has their own needs, right? I mean, I think, from a logistical standpoint, how it worked out for us and how it frankly still works out, is that our schedulers have a list of diagnoses of things that people see, so, me, like I said, I'm not going to be seeing a patient even now necessarily with a new patient with a solid enhancing renal mass, right? We try and get those to the surgeons, obviously, but I'll see the patient who has gross hematuria, right? And I'll work them up. And if I do find a renal mass, then I'll send them to, Aditya, and, he'll work them up and see if they need a partial nephrectomy, et cetera. So, from that standpoint, I think that's worked out really well for us. But the way it works in terms of onboarding a lot of times depends upon the experience of the person you're hiring. A new graduate's different than someone who's been out in practice for 3 or 5 years and frankly knows how to take care of patients, right? I mean, that's part of it. But then also, does the person have experience in urology or not? And, it's important to identify, frankly, what you're looking for ahead of time. And I think you could look at it, two sides of the coin. Some people would say they'd prefer to have a new graduate. Some people would say, I want someone with experience. The people who say they want a new graduate want to be able to mold that person, maybe, right? You don't have to get rid of bad habits, maybe, that have been, incorporated into other clinical practices. So it just really depends on what the needs of the practice are. And I think that what you'll find is that new hire that you have will frankly mold themselves to the need of the practice.
Okay, because I mean, Brad, right now, just so you know, we're in the process. We already hired a person, but we haven't, at least us, I haven't had experience with a PA before. Right. So we already hired. We had 4 candidates, like you mentioned. One was well seasoned, another one no experience, and we ended up hiring one that had a little bit of experience in surgery, that already was taking care of patients. But she doesn't have experience in urology. So she's right now in the credential process and all that. So eventually, how do we start with her? When is a good time for her to not get frustrated with the process? I mean, when at first, how long will it take for her to chow to us? So all those questions are there, and nobody has an answer.
Yeah, no, I mean, I think that's a great question. I mean, I think that's the most common question I get. And I think it all depends upon the person, frankly, and I think it depends on how they matriculate and grow and learn through the process. I mean, I think an important part for you and your group, honestly, is to identify a champion, someone who is going to help mold that person. You need someone to take responsibility, frankly. You need to identify that person in your practice up front, or that person may just be spinning their wheels, trying to find some guidance and some help. I think that when you hire that person and during the interview process, it's mandatory that you set expectations. You need to say, okay, listen, you're going to have to read on your own. You need to give them access to things like the AUA University, et cetera, these online modules, and say, I expect you to read at least one clinical guideline a week or 2 or whatever. Do journal clubs, try and get them involved in, any type of educational opportunities that are there. And I'd say it has to be that expectation. That's what I tell every new hire, outside of our fellowship program that we have, that you need to spend at least 6 months, or you'll just be treading water. You won't be swimming. You'll drown eventually. You need to put forth the effort or you're not going to be successful.
And I think that's very insightful, Brad. Whether we take somebody who's newly interested in research or a new resident without that investment at the front end, which is an investment, but you reap the rewards. So just to kind of recap, it sounds like the bare minimum shadowing would be in the kind of 6 to 8 week range. Is that fair?
Yeah, I think so. Someone with no experience for sure. And I think if you have a new grad, that time may be longer, because you have to teach them how to take care of patients as well, and then I think as they grow, then you can give them more opportunities to see patients independently, but it's a gradual process. I mean, I think it's going to be at least 6 or 12 months of OJT. I think that has to be the expectation going into it.
So tell us a little bit about that supervision process early on. Say you've got, 8, 12 weeks under your belt. The newly hired PA is starting to kind of demonstrate a reasonable understanding of some of the fundamentals of urology. So would you, or just give us your experience on, are you recommending that the PAs see a patient, do a lot of the documentation in conjunction with a physician? Or would it be you're seeing them independently under the supervision of a physician? Could you speak a little bit about to that process?
Yeah, I think early on, the shared visit model makes a lot of sense, right? I mean, that would allow you as a physician maybe to add an extra, 5 or 7 patients onto your clinic with the expectation that that PA is going to be seeing the patient, doing most of the workup, getting the history and physical, and then essentially presenting the patient to you, and then you guys spend a couple minutes talking about it. You go into the clinic or go into the room with the patient and kind of, wrap things up and make sure everyone's on the same page regarding the plan of care, essentially. But, I think that as time goes on, this is a course of months, I would say, you're going to want to give that person more autonomy. After the 10th or 15th microscopic hematuria patient that's been seen, does Dr. Silva really need to go in and see that patient, right? And moving forward, the hope is that that wouldn't necessarily be the case. The hope is that that person will progress to a point at which their skill level and frankly, your confidence in that person is to a point at which you're like, hey, listen, do I really need to come into the room? And that's the goal, is this, team practice model, I would say, over the long run.
Yeah. So a couple of nitty gritties here. So have you run into situations where you have a patient that was expecting to see an MD, or there's a little bit of a difference in expectation at time point 0, and any comments on how to handle that?
Yeah, I mean, I think that starts from the time the patient calls the clinic. That has to do with the back office personnel, making sure there's clear expectations regarding, who the patient's going to be seeing, and yet even with that, sometimes patients say, oh, is Dr. Smith coming in as well? And, it depends on the patient. I'll always offer it. Yeah, sure. Dr. Smith's right down the hall. Do you want me to grab him or not? And a lot of times the patients, frankly, once you present it that way, they'll say, no, I think we're good by now. But I think oftentimes it depends on the confidence level the patient has in you as a provider, right?
Mm-hmm.
If you have confidence and you know what you're doing, I think that will emanate and the patient will be comfortable with the situation. But I think the reality of it starts with the back office in terms of setting the expectations.
And then a couple of follow-up questions, some practical kind of building related questions. In the shared visit type of model, as you mentioned, the PA is able to do much of the work, the documenting, the ordering, et cetera. The physician would be able to see the patient as well. And do the physicians typically bill as the provider for that visit?
Yeah, I would say, the way shared visits work, they can be done both at the inpatient and outpatient setting. And you combine the note, right, in terms of the amount of information that's in there, and then you bill at a level based upon the combined note. The physician has to document what they did, and they have to see the patient as well for the shared visit. And then you can bill at 100% of the physician fee at that time, assuming the physician bills. I would say definitely in a private practice model, if you're doing shared visits, that makes the most sense. It's harder to do that for follow-up patients, unless you're seeing every single follow-up patient with the PA, which ultimately I don't think should be your goal over the long run. There's different requirements that CMS has to some hoops you have to jump through essentially to do that.
So let's say that we're evolving and we've gone from kind of the shared visit model to the independent provider model. Is it as you get your license that you say that physicians X, Y, and Z are my supervising physicians, or do a certain percentage of charts actually have to be reviewed? Is it more theoretical? Could you tell us a little bit about that?
Sure. I think the most important thing starting off is understanding what your state laws are. Each state, in terms of supervision requirements, are different. And so you have to look at your individual state law regarding what requirements there are. In Texas, there's no specific requirements regarding the number of charts you need to review, et cetera. It's a very broad-based supervision. The laws are written broad to allow for application to different practice patterns, right? The practice an academic medical center may be different than a private practice in West Texas, for example. So they're broad-based, and the application is such that it allows the physician to determine what works best for the practice, essentially. Oftentimes. Okay. Some states are different, but oftentimes that's the case.
And then, sorry. For the independent provider, independent visit, now, let's say you're a year out, the PAs has several diagnoses that they're very comfortable with. And when they're billing, is there a percentage that's typically billable at, or?
Yeah. So Medicare CMS will reimburse at 85% of the physician fee rate. Most private payers nowadays are comparable, I would say. Most of them are at about 85%, but the provider has to be registered within that Blue Cross Blue Shield plan, or that health plan, to bill under their NPI number. Sometimes you'll find a private practice plan that reimburses at 100%, but I would say in terms of planning and in terms of revenue, it should be, I think, as a practice, you'd think about 85% of the physician fee rate.
I was going to ask, in terms of the department, when they hire a new PA, are they looking towards the chair model, or just the PA being a provider in that sense, having their own clinic and then just feed the subspecialist?
Yeah, I think it depends on the practice. If you're speaking directly to UT Southwestern, I would say our model is, maybe a little bit unique, and that's evolved over time. A lot of the PAs in our practice, they break their practice up. We do a lot of general urology, but I also encourage the PAs in our department to subspecialize in some area. For me, I do a lot of male sexual dysfunction. I do the majority of the MRI, trust fusion biopsies in our practice. And there are other PAs that do female urology, kidney stones, et cetera. So I want them to be an expert in something. But they also first assist in the operating room on robotic cases as well. And so it's a big part of our practice. And so their experiences are varied. But I would say for the most part, probably about 80% of their practice is independent. I would say maybe 20% of the PAs do work with some physicians in a shared visit model. And that's kind of newer, frankly. That's kind of been an evolution. We've had some needs specifically in our urologic oncology division in terms of helping facilitate new patient appointments and managing follow-up care, et cetera. But that's just been something that's been in the last 2 years.
Yeah, that's really insightful, Brad. And we talked quite a bit about clinic visits. I think when I think about our main aspects of practice, it's clinic visits, it's clinic procedures, it's operating, and then inpatient. So maybe we touch base a little bit on clinic procedures, cystos, MRI, trust fusion biopsies, which you mentioned. Is this general process going to be similar, where it's going to be shadowing, hands-on, moving towards autonomy? Can you tell us a little bit about that? And is there any particular credentialing that's required to participate in office procedures?
Yeah. So just to speak to myself, yeah, that's how the evolution essentially worked for me. It was shadowing and almost like an apprenticeship. And I would say I learned the majority of the procedures I did with Roarborn at the time. And that was mainly cystos and transrectal ultrasound and biopsies. And, over a period of time, he finally, Frank said to me, Brad, you've had more supervised cystos than any urology resident ever. I think you're good. And to me, that was a blessing that I finally got from him saying, you know what you're doing, and at that point, it went, there's different levels of supervision that I transitioned at that point from a, personal kind of direct supervision to more of an indirect supervision, right? Most of the time he was in the clinic when I was doing procedures. But now, frankly, I'm at a satellite clinic and there may not be a urologist, within 15 miles of when I'm doing a cysto or a trust biopsy. So, yeah, I mean, but that has just been in the last 5 years. That wasn't my first year or two of practice. I wouldn't put a new grad in that situation, frankly.
Yeah, I can just maybe comment too from the MD side. We've got tremendously experienced PAs. Brad right at 20 years, and a really tremendous group numbering close to 8 now. And just like any one of us, I think if there's anything that's a little bit outside of our comfort zone, a little bit outside of our wheelhouse, it's nothing more than stepping out saying, hey, do you mind taking a look at this cysto, or do you mind taking a look at this CT? Just like we do with our partners, it's very similar. But what I'm hearing is once the practice determines that you have the skill set to do procedures, whether that's cystos, blue light cystos, random 12-core biopsies, or even MRI biopsies, I can tell you at UT Southwestern, Brad does the lion's share of the biopsies and has some of the best outcomes in terms of accuracy. So is that a fair summary of kind of clinic procedures?
Yeah, from a clinic standpoint, it's really practice based in terms of what you can and cannot do. Now, if you're a hospital based clinic, oftentimes credentialing, privileging goes through the hospital from that standpoint. And so you may have to quote unquote jump through a few more hoops in terms of credentialing and privileging if it's a hospital based clinic. But if it's not a hospital based clinic, then that's determined at the practice site.
Hey, Brad.
So maybe. Sorry, go ahead, OJ.
You mentioned the satellite clinic. So when you started there, was it also 5 years ago, or you started before and then it evolved to start doing procedures based on need, or how was the process that you started doing procedure? Was it based
procedures?
On need,
yeah, the procedures itself I started doing on the main campus.
Okay.
Frankly, it was within the first year of my practice, but that was with, personal supervision initially, right? I mean, it was with a one-on-one with a urologist doing cystos and trust biopsies.
So they were grooming you for eventually being on your own.
Yeah. I mean, at that time, there were no satellite clinics, right? And, we're all in the same clinic space. And so there was always a urologist available, but it wasn't the personal supervision. They weren't in the same room. They were in the same office suite, but not in the same room, when I was doing the procedures.
Okay. So maybe this is a kind of a natural transition moving into the hospital and inpatient setting, and perhaps we can talk about operating. So at UT Southwestern, the PAs are fairly extensively involved with the robotics program, and I would say they do about 95% of the bedside assisting. Can you tell us a little bit about maybe some of the logistics in terms of credentialing, bringing somebody on board who may not have extensive experience, and then even some of the billing aspects of it, which I think can be a little bit nuanced. I know it's a lot, but we'll just have you kind of go at it, Brad.
Sure. From an onboarding standpoint, I think, it goes back to the experience of the person that you're bringing on board. Do they have operating room experience or not? How long has it been since they've been in the operating room? Do they have laparoscopic experience? Do they have robotic experience? And based upon that, you determine the trajectory of autonomy. It's been a long time since I've taken a quote unquote green PA outside of our fellowship program and integrated them into our robotics program. We've had a PA PA urology fellowship program for about 10 years now. And part of that, the first 6 months, they're essentially learning all the different aspects of urology, and including first assisting the operating room. The second 6 months, they function kind of independently, quote unquote, in our practice like any other PA would. But I would say it's probably just like, surgical residents. The vast majority of them can build up a skill set, that's what you would expect. And there have been a couple over the years where, you could tell within the first few weeks or a couple of months that, this person's really going to struggle, and some people just don't have the dexterity to move forward with being able to first assist in the operating room. But frankly, I think those people kind of self-select. They don't look for positions in the operating room if they're not comfortable in that scenario. But yeah, it's a lot of one-on-one, hands-on training, and then like anything else, it's kind of a gradual apprenticeship. My goal is, if I'm training someone how to first assist on a robotic case, I'm going to be scrubbed in, one-on-one with them. They're going to shadow me. They're going to observe me do cases. I'm going to articulate and tell them why I'm doing things. And eventually I'll allow them to do part of the case. And hopefully over a period of time, I'm not even scrubbing in. I'm just standing by, giving them pointers along the way.
And that's for someone while they're doing the fellowship with you, right?
Yeah, but I think it's applicable to other people as well. But I think the hard thing in your practice may be if this is the first PA you've hired, because that's going to also involve a physician being in the operating room, frankly, with you if you're teaching. Where for us, most of the teaching and onboarding that happens is internal within the PA group, because we have 8 PAs with a lot of experience. And, it's very rare that, a physician is going to do kind of one-on-one training in the operating room on the first assist side of things.
Definitely. And it's something that worries me that in some sense, because I don't want her to get, overwhelmed or frustrated from the situation. Maybe I'm not going to be there all the time to teach her. So a lot of things she's going to be to learn on her own. Or at least not at the moment. But it's going to be interesting.
And Brad, is it standard credentialing in terms of ultimately having the ability to do procedures, whether that's robotic prostatectomy, partial nephrectomy, et cetera, or can you tell us a little bit about that?
Yeah, from a credentialing standpoint, I was part of the credentialing committee at UT Southwestern. Sorry about that, for APPs for a while. And essentially the credentialing is, once again, the language is pretty broad. They allow us to first assist on cases within the specialty of the supervising physician. And it's up to the physician oftentimes to dictate what's appropriate or not. And it's fairly broad-based.
And then maybe you could speak a little bit about billing for cases, any kind of tips and tricks to make it as advantageous within, and obviously staying within the legal system.
Yeah, sure. Yeah. From a billing standpoint, it's quite challenging, I would say, from a financial standpoint, to have a physician first assist nowadays on, frankly, any case. The physicians only get reimbursed, I believe it's 16% of the surgical fee to be a first assistant. An APP would get reimbursed at least Medicare wise, 85% of that 16%. And so when you look at it from a dollars and cents standpoint, you'd much rather your partner be in the clinic generating revenue, during those hours than, being reimbursed at a very low rate. And so, for example, if a surgeon gets $1,000 for a procedure, being the primary surgeon, that surgeon being the first assistant would only get, let's say, $160.
Okay. Yeah. And this is something that I'll ask you to speak to this about the variation in practice settings, in practice OR, clinic, inpatient, and impact on quality of life? Because my understanding is dollars and cents wise, it makes the most sense for a PA to be in the clinic.
Yeah, I mean, I think that's fairly that's without a doubt. Assuming that person is productive in clinic, assuming that person is able to do procedures in clinic, and you're not kind of quote unquote restricting their practice to just post-op patients, et cetera, then yeah, I mean, I think what you'll find is that's probably the case for most private practice urologists as well.
And in your own job and in the way that you have impacted the fellowship, which is generally a mix of operative and clinic urology, do you find it gives some satisfaction, some diversity in being in that operative and clinic experience that goes beyond dollars and cents?
100%. I like the variety of in my work schedule, frankly. I think, at least the people we recruit and that we've hired over the last 10 to 12 years, they feel the same way. They want the mix. They want both clinic and they want some time in the operating room as well. And so that's kind of in the DNA of our group. However, there are some private practices out there that they don't have a need for someone in the operating room, and they just want someone in the clinic. And if that's what someone wants, then, that's fine. You just have to make sure you articulate that to the person you're recruiting and hiring. But, I think it depends on the needs of the practice, and it's in our DNA at UT Southwestern that combination is there.
I got a question, Brad. Do you think you already reached your max scope of practice at UT Southwestern in that sense? I mean, or do you think that you're able to do take more responsibilities as a PA?
I mean, I think, from my standpoint, I'm happy with where I am. I think that any professional in practice, I think my experience at least has been every 3 or 5 years, you try and reinvent yourself in some way. You find some new challenge. And I think I've done that through the majority of my career, whether it be in the clinic or developing the fellowship program, et cetera. And so I think as long as you're able to kind of find something new every 3 to 5 years, it keeps you interested and engaged. And so, yeah, I mean, there's going to be something else in the future that I latch on to. I would say the most recent thing I've done is the MRI fusion biopsies. And yeah, I've kind of been there, done that, and I'm looking for the next evolution. And, in urology, that there'll be always something new. So I'm looking forward to that.
And you're doing them in the clinic?
Yes.
Okay.
That's the understatement of the century. Brad does like 100 a week. It's unreal.
Well,
so maybe the fourth just part of patient management, the fourth major part of patient management is inpatient. And if you want to talk a little bit about, that process, I think, of course, there's going to be rounding with attendings, having a familiar face, kind of, getting clinical chops. But what are your thoughts on having PAs function on the inpatient side as well?
Yeah, I think that there's definitely a role. Once again, I hate to be a broken record, but it depends on the needs of the practice. At UT Southwestern, we purchased a hospital near our campus. I don't know, maybe it was 12, 15 years ago, something like that. And that was the first time we had a PA do inpatient medicine, because we had 2 hospitals and we had a limited urologic presence at that other hospital, but they wanted someone there to be able to do inpatient consults, ER consults, et cetera. And so we hired someone to take on that role. Now, as our hospital system consolidated, that role got pulled back and we didn't do as much inpatient. But now currently we have a nurse practitioner that is essentially 100% doing inpatient care, doing rounds with the residents and the attendings, doing ER consults, And it's great. He loves it, and it's a great position for him. I think he enjoys the education aspect of it as well, especially with the interns and the first year urology residents. He has a lot of experience and helps grease the wheels in some way and keep the machine running. That is inpatient urology at UT Southwestern, frankly.
That's great, Brad. And I know we're coming up on an hour here, but if you had advice for a practice of physicians hiring a PA and vice versa for PAs considering joining a practice, what would that advice look like?
I think there has to be clear expectations regarding what the goals are. I think for a practice, you need to have an understanding of really what your true needs are and make sure that a PA or a nurse practitioner fits whatever those needs are. And I think you need to identify a champion, like I mentioned earlier, someone who will be that go-to person. But I think you really need buy-in from the whole group, that being from the office staff to the nurses to the most senior physician in your practice. Because if you don't have that, then, there'll be unnecessary barriers that will make it challenging for that person to be successful. I think the onboarding, the first 6 to 12 months are key. You don't want to lose that person. Frankly, you don't want to lose that person after 3 years. I mean, think of all the education and training you've given that person. You want to make sure that as they grow in their practice, that their professional development, their autonomy grows, and that their level of interest grows. The most frustrated people I've seen PA and NP wise over the years are those in which they're not allowed to grow their clinical practice. They get bored, after a year or two, and then they start looking for another position. And that's not what you want as a part of a group practice. You want someone who is engaged. You want someone who likes their job, and who frankly does a good job and wants to continue to grow professionally and educationally.
Yeah, I think that's incredibly insightful. Certainly, that it's a member of the team. It's somebody just like anybody else wants to keep it fresh, keep it evolving, take on new, different responsibilities. And maybe I'll pass it back to you, OJ, and we can take it from there.
I think I'm good for now. Definitely along the way, I'm gonna have questions. I'm gonna email Brad for sure.
Sure, happy to help.
Yeah.
It wouldn't be the first time.
so you used to, but yeah, I guess my concern, from my part, is just how to keep her engaged, make sure that she doesn't get frustrated, overwhelmed, and that she feels comfortable. Just like you mentioned, I want her to be in the practice for the long run. I don't want him to train her for 1 or 2 years and then leave. So that would be the challenge to keep her engaged.
Yeah, and I think that like many things, the first time's the hardest. And there'll be some lessons learned, right? And I think ultimately the goal would be, if this is successful, then you make that person kind of a quote unquote lead APP in your group, and then it gets easier, right? After you get some critical mass, you get a couple people there, then your responsibility is a little bit easier. I think then the responsibility gets disseminated across the other APPs who are there in your practice to onboard education and set the expectations for anyone else that joins.
Well, that's great, Brad. Really appreciate your insight, your experience. I personally can say that, what Brad's been able to do here for patient care, for growing a department, for starting a tremendous urology fellowship. I'll throw a plug out there for anybody that's interested in urology. It's really admirable. So, again, thank you for spending some time with us on this Sunday afternoon. And, personally, again, it's always a pleasure working with you. Thanks, Brad.